Hi, this is Dr. Robert Trasolini. Today I'll be doing an elbow exam. We like to start all elbow exams with a quick history of where the injury is, if there is an injury or if it's a chronic pain, where the pain is on the elbow, was there any pops or specific events that have occurred, is there any associated pain, i.e. referred pain to the shoulder, down to the wrist, or with specific movements. Is it pain at night or is it pain during an activity, and is it affecting their activity? I think the other important thing is to check hand dominance. If it is their dominant hand versus their non-dominant hand, if you have a pitcher or a thrower or an overhead athlete, is it dominant versus non-dominant hand, because that plays a significant role. The next thing I like to do is get a full observation inspection of the arm. We like to look at the contours of the front of the arm, where the biceps muscles are, where your wrist flexors and wrist extenders are, as well as the posterior portion of your elbow where your triceps attaches. So upon inspection, we want to make sure we're seeing general arrest as well as with certain activities. So we like to check their carrying angle. The carrying angle is the angle from with their arm in full extension. So if you have somebody who has hyperextension, they have a little bit of a larger carrying angle. In most men it's 11 to 14 degrees, and most women it's 13 to 16 degrees, and it could be larger or smaller depending on the type of sport they play. Pitchers have a larger carrying angle, sometimes greater than 15 degrees, due to medial epicondyle hypertrophy. That is a adaptation and not necessarily pathologic. You also want to check for ecchymosis around the area. Is there any bruising? Is there any loss of contour? You also want to make sure you're not missing anything where they're having some wrist pain, shoulder pain, or ecchymosis in those regions that can be referred to the elbow. Upon inspection, we like to look at 4 quadrants around the elbow. The first quadrant is the anterior quadrant, where we're able to palpate the brachioradialis for tenderness. We're able to palpate the biceps muscle for tenderness, as well as some of the extensor and flexor muscles. A special test we like to do in this is to really assess the biceps muscle, if there's any distal biceps tears. And what we like to do is abduct the arm. You want to supinate your hand, and you want to make a muscle. While hooking laterally, you'll feel a hook right in this region, and that's where a biceps muscle attaches. A second test for the biceps, please relax the arm, is to do a squeeze test, similar to a squeeze test in the Achilles tendon. We'll let the arm kind of rest at about 60 to 80 degrees with the hand in neutral position, and we'll squeeze distally. And if it does supinate the hand, that means that you have an intact muscle. If it does not supinate, you do not have an intact muscle. Next quadrant, you're going to want to look medially, where the medial epicondyle is. This happens in golfer's elbow or medial epicondylitis, where you're going to have issues regarding the flexor muscles, and typically people there have tenderness in the region slightly anterior and distal to the epicondyle, not directly onto the epicondyle. And provocative tests are a resisted pronation, so I'll take their hand and I'll ask them to pronate their hand against my resistance, and that's going to cause some significant pain in that region right over the pronator teres muscle. The next part of the medial portion we want to really look at, especially in our baseball players and our overhead athletes, is the MCL. The MCL, when you place your arm at about 40-50 degrees of flexion, you're able to palpate right in this region, distally right by sublime's tubercle, and approximately right by the epicondyle. And this is a region that can be tender in the acute injury. In chronic instability, you can do a valgus stress test. A valgus stress test is with the arm at about 40 to 60 degrees of flexion. You're placing a valgus load, and if you notice widening or opening or pain at this region, that is a positive sign. A second test to do is called a milking exam. In a milking test, we're going to take the elbow, we're going to abduct the arm, hold the thumb in this region while taking your other hand, offering a valgus movement, and you're adding an axial load and a traction, and you can get significant pain and instability of the elbow at that region as well. The last test, which is the most sensitive test in our literature, is a moving valgus test. So we take the arm in a supination fashion, we add a valgus stress, and we flex and extend the elbow. They typically have pain anywhere from 60 to 90 degrees, and that's going to be you're going to notice opening as well as pain in that region. The third quadrant is the posterior quadrant. This you can palpate any palpable gaps right where the triceps insertion is at the olecranon. You also want to palpate the olecranon to see if there's any bursitis or any inflammation in that region as well. Simple tests are a resistance test in full extension to ask the patient to resist my causing her to flex and have an extended of the elbow. That's a proper test to do, or palpating any gaps in this region. The fourth and final quadrant is the lateral quadrant. Now, in lateral condylitis, or quote-unquote tennis elbow, patients are typically going to have tenderness directly over the lateral epicondyle. That's due to an overuse of some of our extension muscles, specifically the ECRB. So multiple tests you can do in this position are with the elbow fully extended, with the wrist fully extended against resistance. They will have pain in this region. If you ask them to relax the wrist and you passively flex their elbow, they're also going to have pain. And another test called the pronation elevation test is where you have them grab your wrist and you're going to bring your arm down, and they're going to resist that. And if they have pain with that, those are all positive signs in lateral epicondylitis. The last instability test in this part of the elbow is the lateral ulnar collateral ligament testing, and that's done one of three different ways. The first test is to do a push-up test with the arm in supination. So you have them step off the table. You're going to grab the table right behind with your arm in pronation first, and you're going to do a little bit of a push-up in that region, and they're going to have minimal to no pain there. Then you'll ask them to supinate their hands and do the exact same test. And at this point, they're going to have some instability as well as pain with that, and those are positive signs. The last two tests are with the patient laying down flat. Please put lay down on your back right over here. Just switch arms. Yeah. And we're going to take the arm above the head. You're going to ask them to try and relax the arm as much as possible. And with a supinated wrist, you're going to do what's called a posterior lateral rotatory draw, and you're going to kind of draw out the radial head, and you'll be able to feel it subluxate. The last test, which is also always a very difficult test, you really want them to kind of relax their arm, and you don't want to hypersupinate, but you want to have the arm in supination, and you're going to be able to see when you extend and flex, you'll see some dimpling right at the radial head region and potential subluxation of that radial head region, which are all signs of posterolateral instability or lateral ulnar collateral ligament tearing or incompetency.